we're going to be talking about neuropathic pain, CRPS, and what can I do about it? So you might ask yourself at the beginning here, why do we even care about this, right? We're hand surgeons. Isn't this like what pain management does? And we should remember that the initial presentation for something like this is usually to us, and it could be a surgical complication. It's always good to know your enemy, like was written in The Art of War. You might also be the one that initiates treatment, and you should keep your eyes peeled because you can cure the right patient who has CRPS or neurogenic pain. So first, we should talk about what exactly is CRPS, complex regional pain syndrome. It's regional pain combined with autonomic dysfunction, atrophy, and functional impairment. And it actually it's a composite injury. It affects all tissue types, musculoskeletal, neuro, cutaneous, and vascular. But pain is really the sine qua non, meaning the without which not, right? Pain is what typifies CRPS. And it's not a psychogenic condition. It's not psychological. It's not depression. It's not anxiety. It's a real thing. You may have heard it go by a bunch of different names, including causalgia or reflex sympathetic dystrophy. Those are the two most common alternate names. But throughout the course of history, it's had many different synonyms. The name causalgia comes from the classic Greek, comes from the origin kostos, which means fever or heat, and algia, which means pain. So the diagnosis of CRPS, I'm just going to quote you briefly the definition from Green's Hand Surgery, which says that the diagnosis is based on the history and physical exam and requires the intuition and experience of the clinician. Green's also reminds us that a dystrophic process should be considered in all patients experiencing pain that is out of proportion to the traumatic or surgical insult and that is inappropriately influencing function or outcome. And largely, imaging, serum biomarkers, and lab findings cannot be used to make the diagnosis of CRPS. Here is that sort of typical appearance where you've got a limb, it is swollen, it's red, it has that shiny appearance. You can even see it glisten here in the photo. And the fingers are held in that typical position of semi-extension. That right there is CRPS. Burn that picture into your mind. It's got that, you can see in this picture from the volar side, the same findings, right? The puffiness, that little shininess to the skin. The fingers held in semi-extension, swelling everywhere. So you can do adjunctive testing if you have access to it. This is really for academic purposes. I don't really order any of this in clinical practice. Thermography, if you have access to it, will show increased temperature. Laser Doppler fluxometry, which measures blood flow, can show the increased flow to the area, and then with cold stress testing, how it fails to rebound after a cold stress test. Bone scans, which you see here, will show increased uptake. And you can see all around the wrist there the increased uptake on the bone scan, as well as around the joints in the hand.
Hey,
this is
Peter, sorry to interrupt.
Yeah.
It's interrupt you here. The slides are not advancing for me. I'm not sure if anybody else has the same issue. I'm still seeing Jeff climbing a tree. So I'm not sure if that's an issue for everybody else there, but oh, now I see it. Perfect. That works. Thank you, sir.
Yeah.
Was they not advancing before, Cesar?
I think right there it's advancing now. You need to, I think you put it on full screen, Peter. There you go.
All right. Well, let me do this. Let me go. Are they going back and forth now?
Perfect.
All right. Do you want me to start over?
Roll it.
All right. So let me start over. So CRPS. So here's the picture I want you to get burned into your mind, okay? Here's the picture. So if you didn't see this before, this is the red, swollen hand, the shininess there. You can see it glistening. This is the picture I want you to burn into your mind. Here it is volarly. Fingers in semi-extension, the glistening of the skin, the swelling of the fingers, the puffiness of the hand, That's CRPS right there. So here's a picture of a thermography scan. You can see in the image on your right, the image on your left, the increase in the whites. That just shows the increased temperature flow throughout. So, sometimes I think about CRPS, like Potter Stewart, who is a justice of the Supreme Court, said when he was referring to obscenity. He said, "I shall not today attempt to further define the kinds of material I understand to be embraced within that shorthand description, and perhaps I never could succeed in intelligently doing so, but I know it when I see it." And we can say the same thing about neuropathic pain and CRPS. Maybe it's hard for me to define, but I know it when I see it. There are the Budapest criteria for CRPS. You can look this up in a book. I'm not going to beleaguer it. It's this very long definition. I think of it as what I call the Pensacola criteria for rain, which might say that, oh, you've got to have a wet coat and cold weather outside and sweating inside my jacket and puddles on the ground. The point being that, you can get early showers before rainstorms. And if you follow this Budapest criteria for CRPS, it's only going to define fulminant, full-blown, flagrant CRPS. It really actually occurs in a much subtle way before it meets this Budapest criteria. So I would encourage you to set this aside, to not use this as the end-all be-all definition of CRPS, but instead understand that neuropathic conditions exist commonly in practice before they meet the full-blown criteria for CRPS. Okay, onward. So medical school is expensive. Last time I Googled it, it was well over $250,000. So we're going to get our money's worth today. We're going to learn some new words. All right, we're going to start with a word we think we all know what it means: pain. So pain is defined as an unpleasant sensory and emotional experience that's associated with actual or potential tissue damage. So, but there's other things that are not quite pain. And that's the ones that I really want you to understand at the end of our lecture today. So pain that's appropriate pain. I hit my thumb with the hammer and it hurts. That's noxious pain. A stimulus that's actually damaging or threatens damage to normal tissues. Now that's a little bit different, right? So if you cut yourself, as hand surgeons, we take care of a lot of patients that cut themselves, right? And when they lacerate a nerve, it's not particularly painful. It's analgesic. They cut their thumb with a knife, and now I can't feel my cigarette burning my skin. That's analgesia. There's an absence of pain in response to stimulation. So here's an interesting one. And I actually do hear this. This is real. When the bed sheets touch my foot, it hurts, doc, it hurts. The bed sheets aren't supposed to hurt. Well, we call that allodynia. That's pain due to a stimulus that does not normally provoke pain. And it's one of the hallmark findings in CRPS, allodynia. Allo means different. Doc, I feel like my fingertips are covered in sandpaper, right? So the sandpaper feeling is not normal, but that's not painful. We call that paresthesias. It's an abnormal sensation, whether spontaneous or evoked. In the case of the sandpaper, it's evoked by touching it. We also call paresthesias the pins and needles feeling. So that's an abnormal sensation to feel pins and needles in your finger when nothing's touching it. That's also paresthesias. Now, what if I feel a painful, burning pins and needles in my toes? We get this a lot with reinnervation pain. We get this a lot with neuropathic pain. This is also pretty typical for diabetic neuropathy. Well, that's called a dysesthesia. That's an unpleasant, abnormal sensation, whether it's spontaneous or evoked. That's a dysesthesia. And then lastly, Dr. Apel, the injection you gave me, painful, felt like a hot poker that was burning my bone. This was the most painful thing in my life. That's hyperalgesia. That is a description of increased pain from a stimulus that normally provokes pain. So the injection normally provokes pain. But for it to be the most painful thing in my life, right, that's hyperalgesia. So when you're describing these neuropathic cases, you want to use language that reflects the patient condition. So use the terms allodynia, paresthesias, dysesthesias, and hyperalgesia when you're describing what you find on your exam. So moving on to classification. So CRPS is broadly categorized into type 1 CRPS and type 2 CRPS. Type 1 you can think about as primary CRPS, and type 2 you can think about as secondary CRPS. So type 1 CRPS is often initiated by trauma. In the case here, you've got a smashed hand, all the metacarpals are broken. You're going to get a CRPS type reaction in that hand, just based on the trauma alone. In other cases, you can get it without such massive trauma. You can get it with more minor trauma, including just a simple fall and then a cast or bandage that was too tight. That's a great way to give yourself CRPS. That's type 1 CRPS, kind of primary type. For type 2, that's where we have an identifiable peripheral nerve injury. And that can be a cut, a stretch, or a laceration. And that's going to be primarily in that nerve distribution, but it can also include, the whole hand. We could also think about CRPS and divide it up into sympathetically mediated or sympathetically independent. And a sympathetically mediated is the classic RSD, right? Reflex sympathetic dystrophy. And that's the foot you see here on the right, that big red, hyperemic, swollen foot. And this is typically what we see in the early phases of CRPS, the sympathetically mediated. And as far as the prognosis goes, what I would tell you is, well, it's not terrible. I mean, is it good? No, it's not good, but it's not terrible. About 80% will improve with appropriate treatment, especially when treated within the first 6 weeks. As CRPS moves on in its disease course to become sympathetically independent, it's a much worse prognosis. That tends to be that cold, atrophic limb, chronic, a couple of years duration of symptoms. And that's a lot less responsive to treatment, as it carries a much more poor prognosis. So in order to treat pain, it is important to understand it. And, the normal pain that we take care of, if somebody has a wrist fusion and they're painful, that comes from damage to tissues as a result of thermal, surgical, mechanical, or other means. Pathologic pain is neuropathic pain, right? This is where the nerves themselves are the origin of the pain. And this is caused by primary lesions or lesions and dysfunction of the central peripheral nervous system. And I'll explain what I mean there for a minute. So primary lesions of nerve is carpal tunnel syndrome, right? That's the most common that we see. It's where there's actual compression of the nerve, and the nerve is the origin of the pain. Dysfunctions of the central nervous system, that's myelopathy, right? You've got spinal cord injury and pain there. And other lesions of the peripheral nervous system, stretch injuries of the nerve, those all cause neuropathic pain. So whenever someone has pain, it's important to look at them and think about what is the origin of the pain. And that will be the guide for your treatment of the pain. If the origin of the pain is they got their hand, run over, and they've got swelling, inflammation, edema, you might treat them with anti-inflammatories, narcotics, elevation, stuff like that. But if their pain comes from having stretched the ulnar nerve, right, narcotics aren't going to help, anti-inflammatories aren't going to help. You've got to address the neuropathic pain. So some people think that CRPS is actually an exaggerated normal response to injury. That the normal response to an injury, right? You run over your hand, you smash your thumb in the door, you get pain, swelling, increased blood flow. Well, that's what CRPS is. And it's thought that CRPS may actually just be this abnormally severe or prolonged manifestation of a normal injury. So here's a curve that kind of illustrates that, right? And so on the y-axis, we've got the degree of abnormal physiology, right? Pain, swelling, inflammation, increased blood flow. And on the On the x-axis, we've got time. So if you look at the little arrow, right, that's the injury. There should normally be an uptick in pain, swelling, inflammation, right? That's the body's healing response. But with time, that should curve back down. So just like that light blue line, it should curve back down with time. These dotted lines here, we think these are the pathologic responses of CRPS. It's where the body's healing mechanisms somehow go awry and they don't return back down to baseline. Now, you see several of these ones here, they do. And unfortunately, that's the natural history of most of CRPS. But some of them take that top little purple dotted line where they just get continually exaggerated and they stay elevated permanently. So part of what it's important to understand is, the peripheral nervous system is a complex organ. And you might ask yourself, how does it affect changes in blood flow? And the answer is it does so through these little itty bitty tiny vessels, these tiny nerves all over the blood vessels. So here's a series of photomicrographs here with B, F, and J labeled from an article that I pulled that really showed the artery, the arteriole specifically in red here, and in green are the nerves. And you can see that nerves just, they blanket the arterioles. These are sympathetic nerves that affect blood flow. We know that peripheral nerves also, the autonomic fibers are also carried by peripheral nerves. So in the previous slide, you saw how they're carried by the arteries, and here you can see how they're carried by the peripheral nerves. This is an old but very elegant study that showed in a median nerve injury on the right, ulnar nerve injury on the left, the differences in temperature that exist with a nerve laceration. So on the left is the ulnar nerve laceration, and you can see just the surface temperature changes, that they're much, much higher. Look at all those reds and whites in the ulnar nerve distribution versus the median nerve distribution with all the cool blues. On the flip side, look at the patient who has the ulnar nerve, the median nerve laceration on the right. Look at all the whites in the median nerve laceration. And so what happens is that with a nerve laceration, the sympathetic fibers are transected, the parasympathetics dominate, they cause vasodilation, and you get increased blood flow and the increased temperature. So peripheral nerves, they're not just motor and sensory, they're also autonomic. Here's another example. This is a child. I'm sure many of you have seen this slide before. This is a child with a recovering median nerve injury in the hand. We performed here what's called a wrinkle test. You stick the hand in the water for a while. The wrinkle test is a sympathetically mediated response to cause the skin to wrinkle. And you can see here the index and long finger don't wrinkle. That's because the sympathetic fibers haven't grown back yet. For time's sake, I'm going to skip this slide. This just goes over the physiology of the sympathetic component of RSD. And then lastly, here's a cartoon that just kind of illustrates, that circular mechanism of RSD, where if we start at the upper right, we see that the brain perceives the injury. It sends the pain. The pain is sensed by the brain. The brain sends down the sympathetic nervous system, which goes to the site of injury to initiate the healing response. The pain triggers additional responses, and it just increases that cycle, and that cycle gets caught in a pathologic mechanism, and that's the pathology of RSD. We try to break that in 8 different ways. Sympathetic blocks are probably the most successful because that breaks that chain. All right, Mr. Osborne, may I be excused? My brain is full. Classic Far Side cartoon. So I'm going to get you back to the clinical stuff. We got a room full of doctors here, not a room full of scientists and PhD molecular researchers. So let's talk about some clinical things here. So, who gets CRPS? Well, the answer is women, unfortunately, about 4 to 1 over men. Average age is 50. We think there's some protection of youth. Upper extremities are more common than lower extremities, and there's an increased risk of smokers. And the single most common inciting event are distal radius fractures. So there's some important iatrogenic causes, ways that we can cause CRPS. One is a tight cast after distal radius fracture. Just remember, it's better to lose reduction and need surgery than to develop CRPS. Malreduction is a fixable problem, easily fixable problem. CRPS is not an easily fixable problem. Other important iatrogenic causes are injury to the palmar cutaneous branch of the median nerve during a carpal tunnel release. That's really easy to get inadvertently. It's typically superficial and radial to where we're operating, but you can certainly get it. You can injure the superficial radial nerve during de Quervain's release, which is why I don't ever use a Wheatlander during de Quervain's, just simple handheld retractors. It's easy to have that Wheatlander twist and fall out of the wound and catch the superficial radial nerve. So, that's such an easy case. It's easy to do just with handheld retractors. And the SRN is right there in the de Quervain's. You really got to watch out for it. You can injure the dorsal branch of the ulnar nerve during your approach to the distal ulna. Unfortunately, I have a couple of cases of mine of this floating around out there. It's a lot easier to do than you think, especially because we don't always expose that nerve, and it can be a struggle to expose the distal ulna. You typically have retractors in, and it's easy to inadvertently put a retractor right under the dorsal ulnar cutaneous branch while you're trying to operate on the distal ulna. The LABC during distal biceps tendon repair, this is universal. We think it's actually a traction injury, not from the retractor, but it is important to be aware of and manage because you'll see it in pretty much every distal biceps case. So that's great, Dr. Apel. I appreciate all the molecular stuff. But, treatment, how am I going to treat these patients? Well, sometimes I feel like treating these is kind of like this other Far Side cartoon, right? Where you got unknown to most historians, William Tell had an older and less unfortunate son named Warren. Come on, Dad, shoot the apple, shoot the apple. And this is what it feels like, right? That you are, you're set up for failure. That in treating these injuries and in treating these problems, that it seems so simple, yet in reality it is so hard. So first, though, I want to talk about surgical and curative treatment, since we're surgeons, and if you can cure somebody, it's awesome. If you want to cure somebody of a neuropathic or of type 2 CRPS, you got to correct. First off, there has to be a lesion, and you got to correct the lesion. You're going to correct it with either excision and grafting or targeted muscle reinnervation, because you have to reset that pathway. You have to reset that pathway where the nerve is continuing to send pathologic signals. So here's a couple of slides for a talk that we're giving next month, and I just want to share these with you. When are the indications for doing, a surgery like this? If the patient has no neuropathic pain, they've failed a primary neurolysis, they've failed excision and implanting techniques, or they've got bad post-traumatic neuropathic pain or an iatrogenic nerve injury, those are generally the indications for exploration with utilization of one of these advanced nerve techniques. The old way of doing these, were passive techniques. So here are some passive techniques where you just cut off a nerve injury site like the neuroma, you just stuff it in a muscle, or you put on one of these nerve caps. Transposition into bone, burying deep, those are all passive techniques. What we're moving to now, what we call advanced nerve surgery, is using active techniques. So that's going to include grafting, like we see here, using either allograft or autograft. Or it's going to include nerve transfers, we most commonly do end to side. Or it's going to be using targeted muscle reinnervation, which we'll talk about again in a second. So here's what nerve transfer looks like for neuropathic pain. You take your small sensory nerve and you bring it to a larger mixed nerve. You can bring sural to tibial, SPN to tibial, SPN to DPN, medial and brachial to ulnar, palmar cutaneous to median. You get the idea. And what you do, though, is essentially you just collapse that pathologic sensory nerve. First off, you cut it back to a healthy nerve, and then you collapse it end to side. For TMR, so some of you may have heard of this, it's called targeted muscle reinnervation. This is an advanced technique that utilizes active nerve regeneration physiology to manage the neuropathic pain. And here's a cartoon of what is done. You essentially take the nerve and stick it right into the muscle at the level of the neuromuscular junction. And I think it's important to understand history, right? Where did all this come from? Now, what about all these new, techniques? Well, nerve grafting is not new. It's been around for over 100 years. But really in the last decade, though, we've really understand the biology of it a bit better, with how much nerve to resect. And we've gotten better and better results with long grafts, with bigger surgery. Targeted muscle reinnervation is new. It was discovered about 2014 at Northwestern. This is the group who discussed this at Northwestern. And here is a graph that shows just the PubMed results for targeted muscle reinnervation over the last 15 years. And you can see, there were 1 to 2 publications a year in the early 2000s, but still less than 10 in about 15, 16, and 17. And it really took off in 18, 19, and 20 because we understood that by taking this end neuroma here, cutting it off, and taking the motor nerve and putting it into the muscle, that you get incredible results from a neuropathic pain management standpoint. And this has been demonstrated by Sue Jordan and others that it's incredible. It really works. This is a level 1 study here that I've got the mask set up for, which was a randomized controlled trial. There are multiple level 3 studies that have shown this as well. For baloney amputations, it's shown a greater than 90% improvement in neuropathic pain, in revision cases, improved phantom leg pain, less than 30% symptomatic neuromas when performed primarily, which is, that number is well over 80 for untreated primary BKs. And so we've taken this understanding of management of nerve pathology and applied it in many other areas. So I want to show you a couple of cases where we've taken patients with neuropathic pain and treated them with active techniques and essentially cured them. Because this stuff is incredible and it's really cool. You can make a huge difference in these people's lives. So in the first case, this was a 19-year-old college baseball player. He had a posterior tibial nerve injury with mixed anesthesia and allodynia. 6 weeks prior, he underwent an ankle arthroscopy. Woke up with terrible pain and has been in terrible pain in the plantar foot since the PACU. Here's his exam. He's got these 2 ankle arthroscopy portals. You see one of them is posterior medially over the side of the posterior tibial nerve. Here's his sensory deficits. You see on the lateral part of the foot, he was insensate. In the medial part of the foot, he had this intense allodynia. He did have some sensation down to the 2.0 gram monofilament, though. So our plan was to explore the posterior tibial nerve with likely resection and grafting, depending on what we found. Here was the exploration. You can see a pretty large zone of injury on the posterior half of the posterior tibial nerve, especially to the lateral plantar branch and the calcaneal branch. There was some preservation of the medial half. So we performed a resection. You can see here he's got a 5-centimeter gap in the medial plantar branch. We did a sural nerve grafting from the other side, laid in there, and it healed up. I won't beleaguer his post-op exam, but the bottom line was this kid got back near full sensation in the plantar foot and went back to playing college baseball. Here's another case. 52-year-old female, open talus fracture, neuropathic pain in the posterior tibial nerve, totally insensate foot. Here's her sensory exam table. Nearly totally insensate. We went in, we did an exploration. You can see here, we palpated the neuropathic zone, and you can feel it feels rock hard. The nerve should feel soft and squishy, like a fresh gummy worm. This part here felt rock hard, like somebody left a gummy worm, out for a year and a half, right? And it's rock hard. So we resected in between, the two purple dots, took the sural nerve from the contralateral side, interposed it into the gap. Here's what that looks like. 2 years later, she's doing great. She's walking around on the foot. She's very glad she had the surgery. Her neurological pain is completely resolved. I mean, these are incredible, right? You can change people's lives. Here's the last case I'll show. 42-year-old male who's 5 months out from a deep perineal nerve neurolysis, terrible pain in the DPN. You can see in the picture here, he's got this big hypertrophic scar over the anterior aspect of the ankle. The X marks the site of the tonal. This patient had failed topical neuromodulators, had a favorable response to an ultrasound-guided injection. So here we went in. So we chose to go well proximal to a zone of injury. So you can see this incision is in the middle third of the leg, well above the site of his scar. So we dissected down. We isolated out the motor nerve to the EHL. That's what you see here under the blue vessel loop here. And the dorsalis, the deep perineal nerve has been cut there distally. And then we stick the nerve in the motor nerve to the EHL. The DPN is stuck into the motor nerve to the EHL. And you see how we leave all the redundancy there? Looks like a little snake. That makes sure there's no tension whatsoever on the DPN. So that's a targeted muscle reinnervation. This guy comes back 6 weeks out. He's thrilled, right? He's numb between his first and second toes, but he's very happy with his result. He's able to shower without pain when water hits the foot. He can put his shoe and sock on without pain. He's comfortable completing all of his job duties and is requesting full release back to work. All right, at 6 weeks. So really just an incredible result from surgical treatment of this neuropathic pain. I'd be remiss if I didn't discuss non-surgical treatment of neuropathic pain. For patients that you're going to treat non-operatively, I would encourage you to do a multidisciplinary team approach. That includes occupational therapy, pain management. You can use topical medications. I really like the 10% ketamine, 6% gabapentin topically. Oral medications, there's lots of different choices. Steroids, the old tricyclic antidepressants. There's lots of choices. For therapy, you can use desensitization, mirror therapy, and also coping therapy, teaching people to manage their problem without seeking a cure. For long-term management, this may or may not be you. If you manage these long-term, you're probably not going to be very busy in your hand surgery practice. You're just going to be managing chronic pain. So I would encourage you to transition these folks to chronic pain management when appropriate. Here's your list of medications for your first-line treatment. These are going to include amitriptyline, which for me is the number one choice. This is a tricyclic antidepressant. The dose that we use there is much lower than the antidepressant dose. You might want to caution patients that it's an antidepressant before you give it to them. Just because when they, there's still some social stigma about being put on antidepressants, and you want to make sure that you're clear with them. You say, look, you might be depressed, but that is not what I'm treating you here for. This is a nerve medication, and it reduces nerve activity, and that's why I'm giving it to you. If they think you're giving them an antidepressant, they think that you're calling them crazy and not taking them seriously. You'd be amazed what people will read into things without you actually saying it. So whenever I prescribe amitriptyline, I'm very clear to say to the patient, I'm not prescribing this to you because I think you're depressed. This is a nerve medication. I'm trying to calm the nerves down. Gabapentin, we use. It was very, very popular probably starting about 10 years ago. It's kind of declined in popularity as we favored other medications and other methods of treatment. It's still pretty common to use. 300 milligrams TID is a great starting dose. It's not the end-all, be-all neuropathic pain treatment, though, I can assure you that. For patients that truly have sympathetically mediated pain and are symptomatic from the vasospasm, you can prescribe amlodipine. It's a calcium channel blocker. You got to be careful, though. People can really get orthostatic hypotension with this. So just watch out and caution them on that. Steroids are a real good first-line treatment if you're catching patients in the first couple of weeks. It can really knock down that physiologic response. But certainly in the long term, there's no role for it in the long term. Topical medications, as I mentioned, I use the 10% ketamine, 6% gabapentin. Therapy focuses on edema control, range of motion, and desensitization. And overall, with non-operative management, you can have a good prognosis if treated early. These patients are never cured. Their symptoms are reduced to the point that they become tolerable. They all end up with residual finger stiffness, but the goal is to get their lives to be manageable. There's advanced non-operative treatment, which is really sort of beyond my scope of practice. It's important for you, though, to know about them. You can use phentolamine or clonidine. Both of these have pretty significant side effect profiles and very narrow therapeutic windows. You've got to be careful with them. Stellate ganglion blocks are great for breaking that cycle that we talked about. Those, I think, should be done in anybody who has failed some of the pharmacologic treatments. And then, things that I really don't get into are ketamine comas, Botox, or bisphosphonates. Those are really for folks that are going to be treating these patients in the long term. So that's it. I'll open the floor up to discussion. I thank everybody for their attention and their patience with the technical difficulties at the beginning of the presentation.
Peter, that was excellent. One quick question: just to explain, when you're doing that neuroma management, like for the EHL, you're not taking all the motor fibers of the EHL. You're taking just a portion of it, so they still have EHL function, right?
No, we're taking all of it. When we do TMR, like in this case here, we're choosing to do something that's expendable. So the EHL is expendable. Yeah, my experience with these is they do end up with a little drop of the big toe.
Okay. I thought there was ways that you could split them and remain some.
Well, some of these muscles will have segmental innervation. And so if they have segmental innervation, then there'll be some preservation. But I'm not overly concerned with preserving EHL or FHL or hemisoleus or hemigastroc. Those are all known to be well-tolerated donors.
And one last question: do you have any issues if you're working on the medial aspect of the ankle, taking harvest sural from the lateral side in the same ankle, or do you always try? Or if you can, you do contralateral? So
I do contralateral. So for all of the posterior tibial nerves, that I do, I take sural from the contralateral. And the reason is that you'll get some reinnervation creep. So the sural nerve will reinnervate some of the lateral foot just through creep if it's denervated. And I don't want to lose that by taking sural from the same leg.